Hello, this is your instructor, Marie Moran. Again, welcome to our class, BC 3020. This week we're covering Evaluation and Management, Chapter 1 of your Next Step book. So the three factors that influence evaluation and management codes are place of service, type of service, and patient status. Place of service could be inpatient or outpatient. Type of service could be a consultation, a hospital admission, an office visit, etc. Patient status, two types, new patient and established patient. So a new patient is one who has not received professional service from the physician or another physician of the exact same specialty and subspecialty who belongs to the same group of practice within the past 3 years. An established patient is one who has received professional service from the physician or another physician of the exact same specialty and subspecialty who belongs to the same group practice within the past 3 years. The history elements are what we call subjective. They come from the patient. Patient walks in and has a chief complaint. Doctor will say, okay, why are you here? Well, the patient might say, I have lower back pain. That will be the chief complaint. Next will be the history of the present illness, the HPI. So the doctor is going to ask during the HPI, okay, how long has this pain, have you had this pain in your lower back? Did you do something that caused the pain? Did you have an accident? What makes the pain better or worse? Might even ask, do you have tingling in your feet? Several questions will be asked during the history of the present illness. Next, the doctor is going to do an exam. We call the exam the review of systems, or the ROS. We may or may not see the past family and social history. It's not taken every time the patient goes to the doctor. But the chief complaint, the history of the present illness, and the review of systems are, at each visit, you will see those. Evaluation and management documentation guidelines are required, and the guidelines are published by CMS, which is the Center for Medicare and Medicaid Services. There are two versions of the guidelines, 1995 and 1997. The provider will select a version for consistent use with all Medicare, Medicaid, E&M services. The text is based on the 1995 E&M guidelines. We use an audit form. On the audit form, the history of the present illness will look like this. We will see the 8 descriptive elements, location, quality, severity, duration, timing, context, modifying factors, and associated signs and symptoms. So we have to keep an eye open whenever we're reading the history of the present illness to see, for example, if doctor is documenting how long the problem or episode is going on for, when does it occur, under what circumstances, what makes it better or worse, because these do count when we're using the audit form and doing our E&M coding. The history of the present illness levels are problem-focused, expanded problem-focused, detailed, and comprehensive. So we have, so you can see brief or extended. Again, levels will be brief or extended with the history of the present illness levels. This information you can find as well at the beginning of your CPT book. So please do take time to take a look at that. A lot of good information there. Next, moving on to the review of systems. This is the exam that we mentioned earlier. Constitutional is going to be the weight and the temperature that is documented in the medical record. We have the ophthalmologic otolaryngologic, cardiovascular system, respiratory, gastrointestinal, genitourinary, etc., etc. So these are body systems. Remember at the beginning in your language of medicine, you learned that I learned about cells, then a group of cells forming tissue, a group of tissue forming an organ, and a group of organs forming a system. Well, now we're looking at the systems of the body. So again, if doctor examines, for example, listens to the lungs, that would be respiratory system. If he is examining the abdomen, that would be gastrointestinal. The review of systems, again, here we go. Problem-focused, expanded problem-focused, detailed, and comprehensive. So this is, again, on the audit form. We're going to see this little chart here, as well as in your Next Step book, Chapter 1. Past family and social history on the audit form will look like this. Past illnesses, operations, injuries, treatments, current medications. If that's documented, then that would qualify for using the past family and social history on the audit form. Family medical history for hereditary and risk is another one. And social factors, both past and present. If doctor documents any of those, then we do have to count them. And the levels for the past family and social history are problem-focused, expanded problem-focused, detailed, and comprehensive. So a completed history section on the audit form might look like this. Here we go. Here are the 8 elements for the history of the present illness. Review of systems, there are a few, 7 of them actually checked off right over here. And then past family and social history, there were 3 checked off there. So we would come up with a level 3 history. Okay, so to assign a history level, all 3 elements, the history of the present illness, the review of systems, the past family and social history, must be at the same level or higher. While the history comprises the subjective information that the patient gives the physician, the examination is the objective information the physician obtains. Here we go. Examination elements that are objective. Again, this is the doctor's findings. You can see right over here what is documented in constitutional. We all know when we go to the doctor, usually the first thing that happens is someone will take our blood pressure, our pulse, respiration, temperature, maybe the weight. So if those are documented, we do count them. And the body areas, in this case right over here that were examined, were the neck and the abdomen. Now, we're going to look at organ systems. So body area and organ systems are different. Doctor may document something about the neck. That would be a body area. Or he may talk about an extremity. That would be, again, that's a body area. It's not an organ system. Below are the organ systems listed for you. And you'll find them in your Next Step book as well. So examination levels right over here. Problem focus contains 1 body area or organ system limited to the affected area. An expanded problem focus contains 2 to 7. A detailed would be 2 to 7 body areas or organ systems, all right, that are related to the chief complaint. Next, we have medical decision making. We have this based on the complexity of medical decision making is based on the diagnosis or management options, amount and complexity of data to be reviewed, and the risk to the patient. So let's take a look at management options. They're going to be stated or implied decisions regarding a plan or evaluation. We may see words like improving, well-controlled, resolving, or worsening, inadequately controlled, failing to change. We may see words like ordering, planning, or performing additional assessments, and referrals to consultations that are documented. Data to be reviewed may be laboratory reports, radiology reports, diagnostic studies. They could be requested by the doctor, or they might be reviewed by the doctor. If the doctor did request them at the time that the patient is there, naturally he's not going to have the results until the patient has the study done. But once the patient leaves and has the study done, the report's going to come back to the doctor who ordered those studies, and he still is going to be reviewing those. So again, if the doctor requested studies to be done, we do count those as an element. Doctor might even review the whole record. There may be relevant findings that he noted. There may be physician-to-physician discussions. All of these have to be taken into consideration. Next, let's take a look at the risk. What does risk mean to the patient? The presenting problem might be a risk, or diagnostic procedures might be risky, and even the management options. Let's take a look, for example, moderate risk, level 3, 1 or more chronic illnesses with mild exacerbation, progression, or side effects of treatment. 2 or more stable chronic conditions, undiagnosed new problem with uncertain prognosis, like a lump in the breast. Acute illness with systemic symptoms, for example, polynephritis, pneumonitis, colitis, etc. So all of this information is in your book. This is not something that you're going to absorb right away, but at least you know what it means when we talk about risk, the risk to the patient. So moving on, medical decision-making elements, again, are going to be the number of diagnoses that the doctor is dealing with and the management options, amount and/or complexity of data to be reviewed, and the risk of complication or death if not treated. The levels are straightforward, low, moderate, and high. Contributing factors that are taken into consideration as well in evaluation and management coding are counseling, coordination of care, and nature of the presenting problem. Counseling, to bill for counseling only, the documentation must support that the time spent was greater than 50% of the face-to-face visit spent in the counseling or coordination of care with the patient. So for example, let's say a patient was there for 20 minutes only. But of those 20 minutes, let's say 15 minutes was spent talking to the doctor, to the patient, counseling that patient. There was no history of the present illness. There's no exam. There's no medical decision making. The doctor spent the time with the patient talking, and it might even be with the family, maybe not even with the patient. Coordination of care is when a physician coordinates the patient care with other physicians or qualified healthcare professionals or agencies. An example would be if he's sending a patient to ordering home health care for a patient. The doctor's going to have to coordinate that care, make certain that he gives the orders to the supervising individuals from the home health agency. And he has to always be following up on what's going on with his patient. So that would be coordinating care. Nature of the presenting problem takes into consideration the level of complexity of the patient's problem or condition upon presentation. It could be minimal, it could be moderately severe, or high severe. Again, time. So again, if the time exceeds 50% or greater than the time stated in the code description, time can be considered for the code assignment. Please take time to look at your codes in your evaluation and management section of your CPT book. And